Today, it is March 1st, 2022, and this patient is having lower back pain at L4-5, L5-S1, and his pain goes into both legs. When I look at his MRI, he's got two disc herniations with annular tears, L4-5, L5-S1, and the L4-5 is bilateral, meaning both sides. So my belief is that it needs to be treated on both sides because he's got short pedicles, congenital stenosis at L4-5, L5-S1, and he's got these bulging discs at 4-5-5-1 that are not that impressive on the MRI structurally in terms of size, but because he's got short pedicles to begin with, they're causing compression of the nerves. Our patient's awake. We're going to get started. Dr. Deuk here, okay? I'm going to give you some numbing medicine. You're going to feel a little stick and burn. This should not be obstructing my way. Just relax. You'll feel a little poke with a little stick and burn. I'm sorry. So at the right side, we're going 4-5-5-1, correct? And on the left side, we're just going L4-5. Sorry about that. You blame the anesthesiologist, all right? Anytime you feel pain, it's his job to keep you out of pain. All right, not me. My job is to create pain temporarily. Watch the needle, 10 cc's injected. It's important you lay still and don't move. If you have pain, just say ouch. We'll give you some more numbing medicine, okay? Deal? Shot. All right, so we're a little lower than we want to be. I'll start a little bit higher. And we're first going to go for that L5-S1. That's always the hardest to get to. Can you zoom that in a little bit for us, please? Maybe, yeah. Oh, you should always be zoomed in all the way. Okay? And if you can't see the needle in the back, you should drop the table until you do. But not go beyond the disc space. Yeah, I'd say half an inch. Good. Shot. There you go. See? That's how it's supposed to be done. All right, now you've done a great job at 4-5, at 5-1 I mean. I can still see a double shadow at the top of the pedicle 5. I say our WAG is off by half a degree. Now look at that 5-1 disc. For those of you who are rejoining us after the last surgery, the last patient had an autofusion at 5-1. I don't know that that's better. I don't know. I'd say that's worse. Try to come back and split the difference there. Yeah. That's pretty good. Why don't we go with that? So, just so you know, the anatomy of these spines is never normal because obviously if people had normal spinal anatomy, they wouldn't be having back surgery. Shot? But because they don't have normal anatomy, they're having back surgery. Shot? So what does that mean? It means basically we're here to fix the abnormal stuff that's causing pain. That's his iliac crest right there. You see that? What do I need? Don't stand and stare. Act. There you go. Good. All right. A lot of times when you hit the iliac crest, I just go a little more medial, and that really makes a big difference. Shot. Let's have some local. No. I mean for the muscle. There you go. Is that a question for me? Shot. I like our trajectory. Let's take another picture. So our lineup is good with the disc. We should encounter the facet very soon. Shot. The facet there is the L5-S1 facet. I need to get around it. Everything okay, Luis? Shot? Uh-huh. Shot? Shot? Yep. So we need to get further around it. I'm bumping up against his facet joint. There's his iliac crest again, Sean. So he has a pretty high iliac crest. I'm gonna have to go higher up. Num num. What that means is that the hip bone over here is peaking up really high. It's forcing me to start higher with my needle. I didn't hear what he asked.
What'd you say, Paul? Say it again, Paul. You don't have a hiatal hernia.
Oh, no, no.
We're not asking that.
We're not talking about a hiatal hernia. We're talking about a high iliac crest.
Iliac crest.
It's a bone. Yeah, it's a bone. And that bone is your hip bone. It's part of your hip. And so when it's really high, I have to start higher up and aim down to get to where I need to be. It just makes it harder. It's part of doing the surgery. These are not easy surgeries to do, and the patient's individual anatomy changes it and makes it harder, unfortunately. But I don't really get to pick and choose my patient's anatomy. They come to me as they are, Shot, and I got to make the best of it. So, Shot, this facet is really wide. It's challenging to get around it. Shot. I may have to start a little more lateral. Shot. Shot. That's not too bad. I can go a little bit lower. Shot. Might be okay there. Shot. Looking better to me. Shot. Oh, you see that arc abnormality in the back of 5? I think we're off by a degree. Let's try arcing. I can't tell if that's better or worse. Go the other way. It looks worse. That's better. That's definitely better. So I think that's the right way. Shot. It should be right there. All right, get an AP. So I'm using the X-ray machine in the operating room, a very special machine called a fluoroscope. And the fluoroscope shows me the spine, the bony spine, and of course the joints around the spine. That looks pretty good. That looks really pretty good. We're at the lateral border of the pedicle. Show them the pedicle so they can see it. Show them the L5 and the S1 pedicle once you get in position. Yeah, that's the pedicle. Circle it. Yep, perfect. And then show the S1, which is further down. Yep, a little bit. Put the arrow there. That kind of circle there. Go lateral. No. Down. Around. Yeah, to the right. You keep going to the right. And now see the black line coming down? Yes. That's it right there. Good job. That mouse sometimes doesn't behave. But that's it. So we're right at the lateral border of the pedicles, which is perfect. Very happy about that. That's really good. Are you comfy?
Yeah.
All right. We're almost done with the hard part. Shot. Any pain? Shot. right up against the disc. This is the L5-S1, and we're on the right side. Everybody agree? Right 5-1 and bilateral 4-5. All right, so here we are. It went in easy. See how easy that went in? That means there's a big tear. You know, a normal disc, you'd have to push hard to get through the annulus. If it's 25 layers of collagen, tightly bound, normal, that thing just slid right in. That means there's a big tear there. So, all right, the hardest one is done. Now we're going to do L4-5. Are you comfy? All right, let's see if this local is working. Apparently it's working a little bit. 7mm incision. So one of the nice things about the Deuk laser disc repair is we do the whole surgery through this small cut right here, just big enough to put the tube in and endoscope. This is true minimally invasive spine surgery. Shot. And let's draw their attention to the facet at L4-5. And once again, you can see the arthritis in the facet joint. That's it. Look how dark that facet is and compare it to the one above it, L3-4. That's more normal. See all that darkness? That's extra bone, thickened bone. We call it sclerotic bone. It comes from abnormal forces at the facet joint level. All right, shot. So we're heading to L4-5, shot. Shot. Everything okay, Luis?
Yes, sir.
Shot. 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 All right, so I'm lined up pretty good, but I'm just stuck on the facet. Shot. There we go. Shot. This is where you enter the foramen. Let's get an AP. So the nerve root that's leaving is going out just above where my needle is. Show them where the nerve root, before you get the AP, show them where the nerve root exits. The L4 nerve root will exit right where, nope, at the top. Just go to the pedicle. See the pedicle of 4? Move that arrow to, yeah, that's the pedicle. Now go to the bottom of the pedicle. There. The nerve root comes out below that pedicle in that space. Circle the space, yes. Yeah, you can almost see the nerve root, actually. Look at that gray blob just under the pedicle. That's it, right where the arrow is, that gray blob there. That is the nerve root, okay? So we're away from the nerve root. We're below it. And now go ahead and do an AP shot. And then we're right in the foramen, the entrance to the foramen. Perfect. This is exactly where we want to be. So it's very important if you do this minimally invasive spine stuff, it's all predicated, the success of the treatment is predicated on the ability to place the needle. It's really about placing the needle. I know I'm making some pain management doctors angry right now because I'm doing their procedures, the needle procedure, but the reality is that after this, it becomes a surgery. So the needle is just the beginning, shot. And then you do a real surgery, which they can't do because they're not surgeons. Man, bouncing. It's like a little trampoline on the disc. The herniated disc, I'm bouncing on the herniated disc. Shot? Are you okay?
He said yes.
All right. You're a great patient, by the way.
You got a phenomenal anesthesiologist.
Yes, you do. Yes, you do. As long as you don't have any pain or the memory of pain, then yes, you're correct.
Definition of anesthesia.
Yeah.
It's a perfect balance and combination between analgesia and amnesia.
That's right. That's what anesthesia is, analgesia, amnesia. All right, can you all see this here, Kevin?
Yes, sir.
So this, you know, I'm a very experienced surgeon. There's really very few in the world that have more experience than me, maybe less than 5. But here I am. I started here. I had to move up to here, and then I had to move up to here. So it shows you that even with all the experience that I have, you still may not get the entry point right, and you have to shift. You have to be able to move and adjust because every patient's anatomy is different. So my first attempt was incorrect for this patient, but you don't know that till you try. All right. Let's get to the other side and get started. We've already numbed this side up. And I just want to check. It looks good. I'm kind of lining it up with the other side, L4. Uh-huh. That looks pretty good. Num num. So right about now I'm going to enter the fascia. And I want to numb things up a little bit, give him some relief. Questions from our audience, Sean?
No, sir.
They know everything as usual, Sean? So once again, I'm aiming for the same entry point in the back of the disc at L4-5, because this is a bilateral 4-5. I'm going to hit the facet as I did before, and I need to go around the facet joint. That's the key. Sean, I'm on the facet now, and I'm going to pull back and redirect. So I'm going to have to do more than redirect. I'm going to have to reset my entry point because I'm too medial, in my opinion, and I want to go a little bit more lateral. So I'm numbing my patient up cutaneously, and I'm going to do the same entry point but a little bit further to the side. Otherwise, I'm pretty happy with that entry point. Yeah, I'm sorry about that. Shot. This is surgery, folks. We are not making gingerbread men or baking cakes. Unfortunately, as many of you know, surgery can be painful, and we try to minimize that by giving numbing medicine and anesthesia, but I cannot give this patient his anesthesia fully yet. Shot, lay still, please, because he's not ready for it. A lot of arthritis here. Shot. Uh-huh.
We have a question from our audience.
Yep, shot.
This question comes from Mike from Facebook. If the arthritis is causing L5 nerve issues down to the foot, are you able to clean that up with the DRDR?
Hey, Mike, thanks for asking. That's a really good question. You know, that's why I always have to look at everybody's MRI myself, because the reality is what's causing that L5 nerve problem? Is it the facet? Or is it a ligament? Is it a cyst? Or is it the herniated disc? And basically, the Deuk laser disc repair, AP, fixes herniated discs. It doesn't fix facet problems or synovial cysts or thickened ligament. So that's why when somebody says they have a nerve root problem, I got to know what's causing it. You know, is it the disc? Is it behind the disc, behind the nerve root? Is it the facet joint? Is it the capsule of the facet? Is it a short pedicle? Is it a hypertrophy facet? Is it facet joint inflammation leaking onto the nerve root? So that's why I've got to look at the MRI, and I've got to look at all the pictures of the MRI. That's why we do what's called a free MRI review, is that, you know, it doesn't cost people anything to send their MRI to me and have me review it for free and give you my opinion. So right now I couldn't tell you the answer because I don't have that MRI to tell you. But most of the time it's the herniated disc that's the cause. All right, so we're low in the foramen, way below the exiting root, and I'm about to enter the 4-5 disc on the patient's left side. So, you know, this patient has done a phenomenal job for us, and I really appreciate him and our anesthesiologist. The last case, if you watch the last one, we tried to get into L5-S1. We spent half an hour to an hour just trying to get in. And every time we went in, we hit bone. I hit bone. And eventually I had to accept that disc was fused already because, you know, unfortunately that last patient waited a long time to get fixed. Not necessarily his fault, but it is the way it was, and by the time we got to it, it's already fused itself. So very rare for that to happen. Great question. Are you comfortable? All right. Now I'm going to just do one quick test, and then we're going to put you to sleep, okay? All right. So basically, this patient mainly wants his back pain fixed. That's why he's here. And I believe the back pain's coming from a disc and another disc. And it happens to be the L5-S1. Sorry, I'm not really left-handed, but it's working. And then the L4-5. So he's got, you could see it on the MRI, a tear and a tear on the left and right at L4-5, a tear at 5-1 on the right with a little high intensity zone. So basically, I believe these two discs are the cause of his pain. Now, if I'm wrong, he won't have any pain. How bad is that? How high did it go? What number? 9 out of 10. Is that where you typically get back pain? He drained that syringe. Look at that. He took an entire 5 cc's and it's still locked in there. Take another shot. Look at that. It's starting to come out a little bit, but you can see the giant tear. Show them the tear at 5-1 with the arrow. We're going to point out the tear. It is huge. Yeah, you could drive a truck through that tear. Show them the top of the tear there and the bottom. Yep, top and bottom. And so that shouldn't be there. That dye should not be there because that should be contained as a ball in the center of the disc. All right, so that was 9 out of 10 concordant at 5-1. All right, so L5-S1, we had a 9 over 10 concordant. Are you okay?
How you doing, buddy? Good, he's good.
Has he gotten any happy juice yet? Yeah? So that's a 9 out of 10 with happy juice. That's pretty good. So you can imagine if he didn't have happy juice, he would be jumping off the table. How bad is that?
Horrible. Is that a 10
Give me a number, 1 to 10, 10 being the worst pain of your life.
10?
Whoa. Show them that tear. That's pretty cool. Show them the tear in the back of 4-5. Right there. Look at the size of that tear. It's huge. And there's a herniation right there. And you can see the dye on the nerve root right there. Yeah, he just showed you. Going up there, it looks like Rudolph's horns. Okay. So we have checked both discs. What did he say this was, a 10?
So you got a 9 out of 10 at 10.
Yeah, he gets to go to sleep now. He's earned it. And when he wakes up, his pain will be gone. Now, that's the pain from the disc that's going to be gone. I've checked him for other causes of pain. He doesn't have any other back pain causes but the disc. All right, 10 out of 10 concordant.
We did it all.
We're good. We got to put him to sleep. And when he wakes up, we'll be done with surgery. Yeah, take your time. That's right. Yeah, that's right. Take your time. You know, he doesn't really respond much to the pain. You saw that was a 10 out of 10. He barely arched his back.
You have some spasm there? Yeah, spasm also.
Oh, he just tightened up a little bit. My point is he's got a very high pain tolerance, so don't be too heavy-handed with the anesthetic. Just, you know, you can go light. I think he's a tough guy. He's going to be able to handle it. Just monitor him. All right, so what we're talking about is every patient has a different threshold for anesthesia and pain, and we have to find every patient's threshold because if you make the patient too sleepy, they stop breathing, and then bad things can happen, okay?
Oh, we're locating the anesthetic plane.
Yeah, there you go, locating the anesthetic plane. So for this patient, we want to keep him comfortable, but we don't want to make him too deep. And there are certain things that I do that will stimulate him more than other things. All right, so we're going to get stimulating in about a minute once I get down to the disc. I would just be gentle with anesthetic on him. Shot. All right, so we're just about there. Shot. I'm going to pull my guide wire back because it's right at the front of the disc. I don't want it to go any further forward. Shot. I'm right at the tear. So at this point, let's try to advance this into the tear. Shot. I kind of feel it starting to go in. Yeah, there's the guide wire. I'm going to pull the guide wire back just a smidgen. And let's go ahead and advance this dilator into the disc. So far, I'm very happy. We've had here's our blood loss, folks. We've lost a drop of blood, maybe you could say a drop and a half or two, but not much. Not like open back surgery. It's just going in. So easy because the tear is so big. I'm going to take the guide wire out. All right, that's us right there. I'm going to have to bring this in further. That tear is like a giant tear. Literally, I barely hit this and it went right in. So what I'm talking about is the wall of the disc that holds the jelly in has ripped from top to bottom, and the jelly has pushed out through the tear. So we're going to go in and we're going to remove the jelly that's stuck in the tear, and we're going to clean the edges of the tear. And by the time we get done, there'll still be a hole in the back of the disc called the annulus, because we're not repairing the annulus. We're literally just cleaning it so that it can repair itself. You know, the human body does a pretty good job of healing itself when given the right opportunity. And that's what this surgery does. It gives this patient the opportunity to heal his own disc. You're doing awesome. Shot? Let's see where we are. Shot. Luis, is it warm in here? 55? 65? All right, let's get the fluoro out. What's the temperature? 65? Humidity is where? What's the dew point? I'm just kidding. All right, look. You don't want kinks in a tube. Alrighty, we are ready to rock and roll. This patient's really done a phenomenal job of keeping still and letting us do our work, and we're going to have this disc fixed pretty quick, and we'll move on to the L4-5. So going down, turning on my irrigation. Why don't you run for the audience a video, Kevin, showing them why do people get back pain or neck pain from a herniated disc? What causes that pain? Spine Institute, and we've published on why the herniated disc causes pain, and it really comes down to a tear in the disc. Laser.
Annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, lay still. You're doing good. Don't pick up.
Stay still, keep your head down. Good
Okay,
job.
so right now we're at the L5-S1 disc. You can see the laser fiber here. That's the glass tube at 12 o'clock. We're actually inside the painful tear, and We're just starting to do the laser disc repair right now. Let me know when I can proceed. You're seeing a little bit of fat right there.
Keep your head, hey, stay still for me, okay? You gotta keep your head in here, okay? Stay still. You're moving around too much, Paul. Good job.
So this would be a good time to check his arms, Crystal,
I got him. He's good.
to make sure he's not trying to prop himself up. That's fine right there. Let me know when I can start. Yeah. All right. Any questions from our audience?
No, sir.
Why don't you go ahead and show the video about how the Deuk laser disc repair actually works. Do you mind doing that, Kevin?
Yes, sir.
The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We're still working on L5-S1. You can see the end plate over there. Just about done at this level. How's he doing, doctor? Yeah, I'm fine. He's really not moving very much yet. So I know you've got to find the right spot for him. But from my standpoint, he's doing good. He's starting to move a little bit. You may want to titrate a little bit more if you can. So what do you think if we were to try to do a case like this with just local? Think we could? I mean, this is the part that hurts.
You gotta give like some Percocets and Valium, I think, or something. Muscle X like Valium or something. Give a little bit of IV Losep.
Well,
Relax them a little bit, you know?
I'm talking about somebody who has, you know, airway, you know, concern. So, I mean, obviously the most painful part is right now because we're in the area of the disc that's causing all of this pain. The annular tear. I would love to be able to give just some more local, you know? The problem is if it gets on the nerve roots, it's going to cause a temporary weakness and numbness in the nerve root.
Slow, deep breath. You're doing great.
All right, just about there. You can definitely see an annular tear. A lot of inflammation here.
Paul, breathe in and out
Keep breathing for us. You're doing great.
Breathe in and out, Paul, okay? Paul,
Here's part of the tear. You're doing good. Everything's fine.
there you go. One more time for me.
Huh? All right. So what do you recommend?
Hey, Paul, can you breathe in and out for me? Breathe in for me one time.
He's talking.
Good. Oh, you know what? Your mask is not on you. Let me take a quick peek here. All right, let's put that back on you. Now we're gonna get some better breathing for you. Looks like, yeah, he's talking.
Right. That doesn't make sense.
I did process it all day.
That's fine.
Sometimes
Good.
the mask drifts out,
Yeah, I understand.
but it really is the hallmark way to do this is with the mask.
That's why we do it. Safest way to do it. And now his epidural fat wants to come to the party. Just about done at this level. Is he doing all right?
Yeah, he's okay. I feel better since we got it in seal.
Just about done. This is the end of the 5-1 right here. And then I can come out and we'll move on to 4-5. So, Kevin, would you show our audience how an MRI can be submitted to Deuk Spine for review for free?
Yes, sir.
How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your MRI images, plus report. You can submit the MRI through the mail, file upload, or medical record release. You can drag and drop or upload images into the form. Things to remember when submitting your free MRI review. All MRI images must be submitted along with the report in order for it to be reviewed. Once your case is reviewed by our team, a patient advocate will contact you. Thanks for choosing Deuk Spine Institute.
All right, welcome back. We are literally just about done here at L5-S1. We've been working on the L5-S1 for a while, and we're going to shift to the L4-5 next. I'm pretty happy with that. Laser off. So let's see if we can see the nerve root. There it is right there outside the tube. Yeah, he doesn't like that. So let me get one more zap in here with the laser quickly. See that little bit of blue right there I want to get? And then we'll be done. All right. Good. All right, we're done here. Scope off. Little antiseptic, betadine, irrigation, dilator. Leave it. Need more irrigation. So we're just cleaning out this disc. We put some antiseptic in. It's called betadine. And now I've put saline in to clean it out. The reason we use betadine, it's always good to irrigate a surgical wound. Where's my medicine? Got to be thinking, what's the next step? Okay, I'm going to take this out, collect your stuff. We're done at L5-S1. Now we'll move on to L4-5. Put a little bit of pressure on the muscle, keep it from bleeding. Guide wire. So while we're applying pressure and getting the fluoro in position, I'm going to place the guide wire at the next disc. We already know that that needle's in the right place, as long as it hasn't moved, which I don't expect it to. Is that us now? There we go, beautiful. All right, so I'm going to remove shot, the needle, leaving the guide wire in place. Guide wire is exactly that, it's a guide. It's a wire that's a guide, and it's a guide for the dilator. That's what it's guiding. The dilator's job is to spread muscles and fascia and create a little path for the tube. Shot? So look at the size of that tear we're coming up to. The herniation in the foramen, the tear. Shot? So I'm right up against the tear. I'm going in now. This is L4-5. This is the worst painful disc for him. We're doing both sides of this disc. This was a 10 out of 10 pain. Take this and this. Shot. So we're inside now. Shot. That's perfect. I'm going to bring this tube now. So the dilator's job is to create a path for the tube, a safe path. Okay, if you just stick a tube in somebody's body like this blindly, you're going to do a lot of damage. So you have to guide the tube properly, and that's what I'm doing. We doing all right there, doctor?
Yep.
Shot. The x-ray then tells me where these things are. You're doing great. Everything's okay.
Give me a little more, buddy. Hang in there.
Shot. Good. Shot. Perfect. All right, fluoro out. So we've already done one disc. We're getting ready to do our second disc. This patient's having really 3 areas treated and 2 discs. So any questions?
No, sir.
Let's show our audience the difference between, you know, this type of surgery versus the alternative, which is a fusion.
Yes, sir.
Surgery is no better than fusion. surgery, which I knew from the beginning, which is why I don't do artificial discs.
A comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Welcome back. We're just about done. There's a blood vessel I just coagulated with a laser. I don't know if you saw that. Like it was basically a little venule or arterial. Can't really tell, but it was bleeding. And if you rewind the video, you'll see I just hit it with a laser. So one of the things that a lot of doctors don't realize about lasers is they can stop bleeding. Not from bone, but they can stop bleeding from a blood vessel. They're very powerful coagulators. They coagulate the blood vessel. So if you get bleeding while you're operating, your laser can actually stop the bleeding. You can see this is a bloodless surgery. There's no blood. I think we're going to lose 5 drops of blood by the time we're done. That pink thing over to the right there is the end plate. That is literally the surface of the bone that the disc is attached to. And the disc, you can see, is literally just gone in that area. This blue stuff is the herniation, the white stuff is the tear. And I'm just getting the tear cleaned out, getting rid of all the pieces of herniation. The blue stuff is degenerated disc. There's a herniation right there. Just about done. There's the epidural space, a little bit of fat, some veins. And there's a nerve root that's going to be running underneath there. We want to stay away from it. And it's one of the advantages of this surgery is you really can't injure it as long as you're, adhere to a few principles. One of them is don't pull back too far. I'd like to get a little bit more medial. right here, because there's still a little bit of herniation right there. Just about done.
Couple slow deep breaths, buddy. You're doing great.
I need one more minute with this disc, and then I'm going to move on to the left side at L4-5, the last thing we're doing. So we've done the right L5-S1, the right L4-5, and I'm about to switch over to the left L4-5, and that will be it. So this is going quite well for the patient. Right here, just going to clean up this annular tear, and I'm going to pull out. Okay, laser out. Just wait, keep it. The nerve root will be up there in the fat, but you can't even see it because it's buried in fat, which is good. And that's where the herniation was. Let me get a little bit more. And just right here. Any questions from our audience?
How long is the recovery time for this patient?
So the question is about recovery. How long is the recovery? The recovery is 1 hour for this surgery, and then you go home. It takes a year for the disc to fully heal, but most people can go back to light duty usually within a week. All right. Thirty seconds. What's happening is I'm shaving down the herniation here and cleaning the annular tear. More disc is dropping in from the roof, which is really the epidural space. So I just don't want to leave it. I want to make sure I get it all, even if it takes time. We don't mind being here a little longer just to get it done right. This whole area will heal by itself. The patient will heal it, and it takes a long time to heal. That's the only problem. It really takes, but it doesn't matter whether you have this surgery or another surgery. Discs don't have any blood supply, so they just take a long time to heal. So if there's a way to speed up healing, it would be good. Laser scope off. All right, we're done here at L4-5 on the patient's right side. As you can see, there's really no blood loss. We'll do a little antiseptic, some betadine. Irrigation. More betadine. Sorry, more irrigation. All right, so we've irrigated nicely and gotten the betadine out. What we're left with is just the defect within the annulus, that basically hole which has to heal itself. Taking the tube out, putting pressure. Once again, the pressure is to stop any muscle bleeding that might happen. We don't want to just let it bleed. So you put a little bit of pressure for a couple of minutes and it literally stops any muscle bleeding. Let's go lateral. And I'm not really doing anything anyway. I'm waiting for the x-ray machine to get positioned properly. So while I'm waiting, I'm applying pressure. Hold on. Let me move these cables. All right. Let me get the guide wire, please. Thank you. Shot. So we need to have the fluoro down a little bit, just a little bit. All right, table up a 1/4 inch. The other up, that's good. Shot. All right, perfect. So you can see the front of the guide wire at the front of the disc. It's going through the tear. And now I'm going to make an incision. Meanwhile, I'm still holding pressure. I can do two things at once, multitask. Incision. This is an 11 blade. A number 11 is unique in that it has a sharp tip. It's pointy. Of course, they all have sharp edge, but look at the tip of this thing. See how sharp that tip is? So a 15 blade is curved, the 10 blade is really big, but the 11 is perfect for this application. All right, come on over here and hold pressure. Yeah, take your time. Take your time. You got it? All right. It just needs another minute or two. And I'm going to switch sides with you. I'm coming over to the patient's left. All right, so I've already put the guide wire. I'm going to made the incision. I'm taking out the needle. I'm going to next bring this dilator. Yeah. This dilator down the guide wire. How is he? Good. All right. Shot. Yeah, once again, we're not cutting anything. Well, he doesn't like that. So when I see the patient move, it means he's a little light. We want to let the anesthesiologist make him sleepier. Just lay still and then I'll proceed. So I'm going to wait a minute. How does this look? Pressure for one more minute just in case. And it's not on the incision, it's on the track where the tube was. Yeah, you sure?
Yep.
All right, very good. So I'm going to pull this guide wire back a little since it's sitting at the front of the disc. Shot. Good. And I'm going to advance this dilator down through the foramen. I know it's below the nerve root. Yeah, he's still feeling a little more than I want him to. Shot. Take your time. Take your time. Patient safety is always number 1, 2, 3, 4, 5 here. On a scale of 1 to 5. So we always want to make sure our patients are safe. And the anesthesia is the most important part of being safe. All right. How is he doing, Crystal? He looks a little airplaned. Maybe his arms are uneven. If you can help.
Could be shoulders, I think.
Great. Everything's good?
Yeah.
All right, let me know when I can proceed.
Okay.
All right. So let's show the audience where we did the surgery. Look how small this incision is, folks. See that?
Yes, sir.
Kevin?
Yes, sir. We see it.
7 millimeter. And because he has leg pain on both sides, we're treating both sides. Proceed. Seems to be unresponsive. Shot. Okay. Good. This is going to be the most painful part for the patient because we're literally going right through that painful tear and we're basically pushing his herniation back in. So I can empathize with the patient. The nice thing is, since this is the painful part of the disc, we're right where we need to be to fix it. And we're not going through, unlike traditional spine surgery, microdiscectomy, laminectomy, fusions. the surgeons are destroying the normal parts of the spine just to get to the part that's damaged. Whereas with this transforaminal surgery, we're not destroying anything except we're making a cut in the skin. And we're going through a hole that's already in the spine, just below the exiting nerve root. As a matter of fact, we're entering the spine right where the herniation is. Sean? So you can see I'm advancing the tube. We're actually inside the disc at this point. I think we're in far enough. Sean? Yeah, we're in. This is it. This will be our last disc side. Once again, this is the L4-5. Any questions from our audience?
No, sir.
And we've already done the comparison video, right?
Yes, sir.
Yeah. Let me have that. You go get something else. All right. Don't forget, Deuk Spine Institute has got an app that you're welcome to download for free. And we have a lot of great information in there, pictures, explanations of things like herniated discs and facet pain and all kinds of things. And it's all there for you to learn more about your spine problem. We also offer free services to the public like MRI review. These broadcasts of spine surgery are free. We don't charge. We do it for educational reasons, to educate the public. I make myself available as a board certified neurospine surgeon, you know, to answer questions for the public. So in case they want to know something, we don't charge for question and answer, or, you know, we just answer the questions for you and try to educate you. All right, good. Laser. Any questions from our audience?
No, sir.
All right, we're going to bring the laser in and clean up this side of the tear and herniation, and we'll be done. We have a Raytech on the floor. Hope you've enjoyed watching the surgery. Our first surgery today has already gone home, and that patient traveled from Mississippi to have a herniated disc in his neck fixed with the laser endoscopic surgery. He didn't want to have a fusion. He was offered ACDF but didn't want it. And I saw him before he left, and he was doing fantastic. His pain was gone in his arm. His tingling that he had before surgery in his hand was gone. So he was already on the road to recovery. Oh, and his strength was normal. I checked his strength. Before surgery, he had weakness. After surgery, he had normal strength in his biceps, triceps, shoulder, on the side that we fixed. So we could actually see the nerve and the spinal cord in that surgery. You could see that we got the pressure off of it. A lot of people wonder, how does the laser work? Well, what it does is it delivers a blast of energy right at the tip of that glass probe. So anything I touch with the laser glass, it literally delivers the energy right to that tissue, which is so much energy that it vaporizes the tissue. They were talking in the news the other day about this war going on in Ukraine. Russia has invaded Ukraine, and they were talking about all the weapons that Russia has, they're using. One of them is some device that supposedly vaporizes people with energy. Well, I don't know if it's true or not, but it sounds like a pretty scary device. But that's what this laser does. It vaporizes the herniation, breaks it up into small little pieces. It gives so much energy to that little herniated fragment that the herniation cannot hold itself together. It literally breaks apart into 1,000 pieces. and they're microscopic pieces that this end up going up the tube and out. Did you have a question, Kevin?
No, sir. I haven't said anything.
All right, so we got about 5 minutes left, Doctor. Dr. Berndes has done another amazing job with the anesthesia. Thank you so much. This is the tear right here, by the way, right where the glass fiber is. So a lot of people don't understand the laser. I didn't understand it when I first saw it. But the energy doesn't come from the tip of the glass. It's actually generated through a machine that's in the operating room. It's a really big machine. And it has wheels and it rolls around and we can move it in and out of the operating room. We plug it into the wall. It takes 220 power and it basically generates a burst of laser energy, and that's what travels down this glass pipe from 6 feet away, and the glass pipe delivers it to where the surgeon points it. So it's still a surgery because it requires a surgeon to move the fiber and deliver it. So I'm constantly, it's like Tetris, you know, I'm constantly moving the tip to where I want it to work and break up that herniation material, but I'm also looking at the same time in my peripheral vision at what's the next target. So I don't go one, next, otherwise we'd be here all day, and that's not good for the patient because the longer they're under anesthesia, the more risky it is for them. So I have to constantly be looking for the next target. And sometimes it just appears out of the blue. You like that? Out of the blue? All right. Now this patient traveled from Arkansas to have surgery here. The first patient traveled from Mississippi, and the last patient traveled from New Smyrna, but actually originally France. The second patient, yeah. All right. I sometimes have patients who get a little bit confused about what we do here, but the Deuk laser disc repair repairs discs, and we call it a repair, but it's actually the body repairing the disc. We're doing a debridement, but we're doing more than a debridement. So, you know, rather than come up with a long and complicated description of every step of the surgery, we decided to call it the Deuk laser disc repair. And basically, this surgery treats disc problems, but some patients have more than disc problems. They have problems in other areas of their back. For example, the facet joints. The facet joints are a different type of joint in the spine, not really related to the disc at all. They're behind the disc, and they're one of the most common causes of back pain, facet joint pain. Another cause of pain is very common, is called the piriformis muscle. And when you get a tear in your piriformis muscle, you get pain in your lower back. It feels like it's in the back, but it's actually in your buttock, in the butt cheek, kind of like dead center at the top part of the butt cheek. And the thing about the piriformis syndrome that confuses a lot of people is that the sciatic nerve literally runs right through that muscle, and it goes down your leg, obviously. So if the muscle's torn and upset with inflammation, it gets on that sciatic nerve, and it can actually cause sciatica and even kind of a radiculopathy. So There's other causes of back pain like sacroiliitis, which is inflammation of the sacroiliac joints. Very painful. Most commonly seen, you know, after fusion surgeries, where people get a L5-S1 fusion. Puts a lot of stress on the SI joints. As a matter of fact, we're going to be doing a SI joint fusion soon here at Deuk Spine coming up in about a month. A patient with a sacroiliac joint inflammation pain has had shots. Shots worked, but didn't last. So we know the pain is coming from the SI joint, but we offered the patient, you know, stem cells, injections, and rhizotomy of the joint, which would be the next step normally, but she didn't want it. She just wants a fusion. So we're going to be doing an SI joint fusion in the next month or so, right, Luis? And that will be a good one to watch. We've not broadcast one of those before. We've been broadcasting for almost 9 years now, every week that we do surgery. Which, by the way, we will not be doing surgery next week. I will be out of town, and Dr. Patel will be here doing his thing, pain management, but I will be out of town for the week. Back the following week to do more surgery. So now, for those of you who follow us regularly at Deuk Spine, we're going to be doing some different kind of surgery on Thursday. We're actually doing something special. It's not really spine surgery. We're going to be doing carpal tunnel surgery. We have 2 patients with carpal tunnel syndrome. The first one actually has had carpal tunnel surgery before, and they have compressed the nerve. So they grew back, probably scar tissue mostly, and they now have their symptoms of carpal tunnel syndrome back. They're going to have another carpal tunnel release. And that will be our first surgery on Thursday. The second carpal tunnel patient is going to be a patient who's never had a carpal tunnel release. And we're going to be doing a carpal tunnel release on that patient. As a matter of fact, that patient has both wrists affected with pinched nerve. The nerve pinched is a median nerve, and that nerve runs through the carpal tunnel in your palm, and it's getting pinched by what's called the transverse carpal ligament. And we're going to be opening up the transverse carpal ligament, cutting it, and releasing the pressure on the nerve. Now, I don't know if we broadcasted I think we've done a carpal tunnel release before. I need 1 minute. In the past, I think we broadcast them maybe a year ago. But we'll do our very best to show you as much as we can. It's hard to see because of the very small space we're working in. I'll be using a headlight and loops, so we'll do our best to let you see what we're doing. Okay, literally just seconds away from being done. I want to look at the nerve root. It's up there. There's still some herniation there. So I'm going to swing around and address that. All right. Just about finished. 30 seconds. A little bit of this tear and herniation right up here. Any questions from our audience?
No, sir, not at the moment.
All right, I'll be there to answer your questions. I recommend you type them up for me. I'll do my best. But we're just about done here. 10 seconds. And type up your questions for me, okay? All right. Very good. Happy with that? Very happy with that. No more pressure on the nerve and the tear has been cleaned up. Thanks for watching. Great job, everyone. Let's clean this out.
Paul, how's it going? You're all done, Paul. You're a good patient, Paul.
You're a good anesthesiologist, Dr. Bernadette. For sure. Yeah, Paul did a great job. He made your job almost easy.
Yeah.
Almost
I was
easy.
expecting it to be more greater level of difficulty.
Yeah, you count your blessings when they happen. Any questions there, Kevin?
No, sir, not at the moment.
All right, so let's show our audience just the smallness of the incision and how wonderful this surgery can be.
It's a whole anesthetic with no narcotic.
That's great. All right, so we got everything out.
You're all done, buddy. I need you to put your head down. You're finished. Paul, you're done.
Now the right side, you already closed it, Luis, it looks like? Not yet? Lay still.
Still, you're doing great.
Let's get it done.
Yes, sir.
So the whole surgery is done through that little cut. Can you see that, Kevin?
Yes, sir.
And we had to do a similar one on the other side. Go ahead, come on over here and hold pressure here. All right, I'm going to head over and answer questions. I'm very happy with the surgery. I got done everything we needed to. There were no surprises. And I'm going to go check on that last patient and make sure he's doing good. He's ready to go. Thanks, Kevin. You guys did awesome. Thank you very much. Crystal, great job. You learning? Yeah. You like it?
How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your MRI images, plus report. You can submit the MRI through the mail, file upload, or medical record release. You can drag and drop or upload images into the form. Things to remember when submitting your free MRI review. All MRI images must be submitted along with the report in order for it to be reviewed. Once your case is reviewed by our team, a patient advocate will contact you. Thanks for choosing Deuk Spine Institute.
Dr. Ardik Majan here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L4-5, L5-S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it out because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well. And I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Ari Deuk-Majan. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes,
How are you feeling today?
unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
No, absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you said, what are you going to do now? They said, I'm going to Disneyland. You already went, I could see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you, and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk-Majan. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Go on.
And is that because we have you doped up on powerful painkillers?
Nope, none
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep, yes they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while,
Yes,
but the symptoms came back.
came back.
Yeah. All right. Well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. I did arthroscopic.
That's right. Arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. I'm very happy.
You're smiling.
Yeah, I tell you.
Congratulations.
Thank you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery's done, what are you going to do?
I'm going to go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I'm very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes
How to request a free MRI review. Who are we and what we do? With world-class physicians on staff, the newest and most advanced technology, Deuk Spine Institute has performed thousands of procedures and achieves a 95% success rate in elimination of pain. Treatments? Every patient comes to us with a unique set of challenges. That's why we address every patient's care individually. These are some of the world-class treatment options available at Deuk Spine Institute. Deuk laser disc repair, Deuk spinal fusion, rhizotomy, epidural injection, kyphoplasty, physical therapy. Meet Dr. Deuk, world-renowned board-certified neurosurgeon. Go to www.mri.deukspine.com. Click the Free MRI Review tab on the upper right. Complete the patient information form. Continue to fill out Step 2 of the form. Make sure to submit all your MRI images, plus report. You can submit the MRI through the mail, file upload, or medical record release. You can drag and drop or upload images into the form. Things to remember when submitting your free MRI review.
All MRI images must be submitted along with the report in order for it to be reviewed. Once your case is reviewed by our team, a patient advocate will contact you. Thanks for choosing Deuk Spine Institute.
Dr. Ardik Majan here at Deuk Spine Institute, and it's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L4-5, L5-S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it out because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
Agent, CEO, and founder of the Deuk Spine Institute here in Florida, and the founder and pioneer of the Deuk Laser Disc Repair. Welcome to our broadcast, and we have just finished our 3rd Deuk Laser Disc Repair of the day. The first one from this morning was a C5-6 right approach for left arm pain from a pinched nerve due to a herniated disc. At C5-6, the herniation was off to the left side. That patient traveled here from Mississippi, and he is already gone. He left an hour after his surgery was finished. And he has no more arm symptoms. He's very happy. Second patient was a gentleman from France who's living now in the United States. And we fixed 2 discs in the lower back, but the bottom one turned out to be fused when we got in there. Now, we hadn't seen him in about 6 months. Since his MRI was done, and at that time there was a lot of inflammation in that L5-S1 disc. So it doesn't entirely surprise me that it fused itself, but I just checked on him. He's already on his way out. He's very happy, all smiles. His pain is gone. So the last patient we just finished, this one that you're watching now, this patient had a herniation at both sides at L4-5, kind of pushing up into the lateral recess and the neural foramen. So what do all these terms mean? Well, it's a great question, and most doctors don't even know the answer to these questions. So let me see which model is going to be the best one to explain it to you. I'll take a shot at this one. This is going to be a little tough to understand, but let's just look at the spine for a second, okay? This is the front, and this over here is the back. There. All right, this is where the disc sits. So normally a disc would be like this on top of the bone and between the two bones. So like this. All right, so let's look at this disc. Can you guys see that pretty well right there? All right. So this is the Deuk spine model, since they don't have a model like this. All right, there are different types of herniations. Can you tilt the camera down a little bit?
Yeah.
It might be better if they tilt it down. I'm going to explain to you the different herniations, okay? Because I think this is going to help people understand it better. You know what? I got an idea. Maybe this will work, maybe it won't. No, that bone is too hard. All right, so this is the front of the disc here. This is the back of the disc. You can have a herniation directly in the center. It's called a central herniation, okay? These things do cause back pain, but they don't affect the legs because the nerves to the legs go off to the sides. So they miss the herniation. Then you can have a paracentral herniation, which would be right here. Then you can have a lateral recess herniation, which is over here. And then you can have a foraminal herniation, which is over here in the foramen. So then you can have an extraforaminal herniation, which is over here. So you have extraforaminal, foraminal, lateral recess, paracentral, and central. All right. Now, you can also have herniations on the side of the disc, the front of the disc, the back of the disc. There is something very special about the nerves running along the back of the disc. All of these nerves are pain nerves that travel up to the brain, and they go to a part of the brain called the primary somatosensory cortex, which is where sharp pain goes. The nerves on the side of the disc and the nerves on the front of the disc, they're visceral afferents. They don't go to the primary somatosensory cortex. They go to the brainstem, pons, medulla, and basically those pain signals are blunted. You don't even really aware of them. They go to subconscious areas where you're never aware of the pain. So this is a very important point. And 99.99999% of surgeons don't even know this, because literally I discovered it here at Deuk Spine. And they don't listen to me. So maybe in the future they will. But the pain fibers along the back of the disc are somatic afferents. They, by definition, project to the primary somatosensory cortex. That's why people have horrible back pain, very focal, very localized, when it involves a tear with inflammation in the posterior annulus. Again, I'm the one who discovered the tear in the posterior annulus, the inflammation, the somatosensory, primary somatosensory cortex projecting pain fibers that are called somatic afferents. This is all what I figured out over the years of treating people with disc injuries. So I've been trying to spread the word so more people understand it and can identify it and can treat it. But it's difficult. So there you have disc herniations. Now this patient we just did, he had a herniation and tear on both sides at L4-5, this side and this side. And they were bulging back, hitting the nerves coming out of here, okay? So if you look in the back of the disc right there, right where the herniation was, okay, the nerve comes out here and runs down like this. So the herniation bulging out back here was hitting on the nerve. Now look at this hole right here. This is a big hole. It's called a neural foramen. The nerve isn't that big. The nerve is tiny. It's literally probably the diameter of 3 of these toothpicks, okay? So 3 of these toothpicks is about the diameter of a normal nerve root. So there's a lot of extra room in there, a lot of extra room. But when you have a short pedicle, that's this bone right here, that's the pedicle, and that's the pedicle. When those pedicles are shortened, then this hole where the nerve comes out is narrower. And a herniation right there doesn't have to be very big to hit the nerve, because this whole thing back here is pushed forward. The posterior complex, or the facet joint, moves forward because these bones are shorter. These pedicle bones are shorter right here, that one and that one. So that pushes the facets forward, and then a bulging disc will hit the nerve and cause leg pain. This is what most surgeons don't understand. So they ignore it. They just don't get it. But a congenital stenosis that you're born with, which is a bony stenosis of the normal bones being short, predisposes patients to having small bulges that look small in the MRI but end up causing horrible leg pain because of congenital stenosis. So, you know, there are good surgeons that understand it and they get it and they figure it out and they can help patients by fixing it. But unfortunately, most spine surgeons don't even have any clue what this stuff is. That's why it's important you go to the right place to get diagnosed. All right, what's our first question?
Is this the future of spine surgery?
Is this the future of spine surgery? Of course it is. Thank you for asking that. Yes, absolutely it's the future of spine surgery. But the problem is, I'll be honest with you, endoscopic spine surgery, you know, I didn't invent endoscopic spine surgery. I've modified endoscopic spine surgery and added a treatment which is annular debridement to allow the disc to heal and become painless, so you don't have the back pain anymore. But endoscopic spine surgery was pioneered by a doctor by the name of Parvis, P-A-R-V-I-S, Cambin, K-A-M-B-I-N. Dr. Parvis Cambin was an orthopedic surgeon at the University of Pittsburgh, and back in the 80s, 90s, he developed the transforaminal approach, which is basically what you saw me do today. Coming from the back and the side and, you know, going in to get to the disc this way, okay? Rather than going through the bones and ligaments and ripping them out, called a laminectomy, which is what everybody else does. So Cambin figured it out. He was the first one, and he's been teaching a couple of surgeons. Then those couple of surgeons taught, one of them taught me, a couple of them taught me. So I was a second generation, really, maybe even third generation, depending on how you look at it, of spine surgeons that were taught endoscopic surgery. So here's the deal. In the United States, this surgery would be happening everywhere if it wasn't for very powerful lobbying by implant companies like Medtronic and Deuk and Sophomore Danik, used to be Synthes, and big companies that manufacture Alphatec, Nuvasive, Globus. I can keep going, but there's literally 50 companies that make these screws and rods, and the laser surgery you just watch will literally put them out of business. Will shut down 99% of their business. So they also make the metal plates for the neck. They make all kinds of stuff, cages, right? They cost them probably literally, that's polyether ketone. That cage probably cost them $10, $15 to make. And the screws probably cost them literally $30 to make. They're selling these not for $30 and $15, they're selling them for $5,000, $10,000. So the profit margins are massive. And there's one thing we know, greed corrupts people, it corrupts processes. So those companies that are making billions of dollars in profits a year, putting screws and metal into your spine, they're never gonna just give up and roll over and say, oh, endoscopic spine surgery, wow, it's so much better. Come on in, take our business away. That is not happening. And I've been promoting this technology now in the United States and even overseas. I've gone to Hong Kong, given talks. I've gone to other countries. I'm going to Los Angeles. It's kind of another country, right, this month to talk. Actually, I'm doing it virtually. But anyway, point is, they're not going to just roll over and die and secede. You know, hey, you're better. Come on in. Do this for patients. They love it. So the implant companies are fighting it, and they're multi-billion-dollar companies. And the insurance companies don't want it because everyone's going to line up to get it done. Who doesn't have chronic back pain, right? Who doesn't want to get it fixed? So the insurance companies are looking at huge numbers of patients that want to get their back and neck fixed with endoscopic surgery. So they don't want to pay for that because that's going to eat into their profit. So unfortunately, we have very powerful forces in America that are opposed to the propagation of this technology. So is it the future of spine surgery? It already is. Unfortunately, it's more of the future of spine surgery and the current spine surgery in other countries like China and Korea. where those corrupt companies can't stop the surgeons that are doing good things with endoscopic surgery from helping patients. So they're a little bit more down to earth, and their priorities are better. Unfortunately, in America, we've got a big uphill battle to fight. That said, I already have lawyers in place that are filing documents and appeals, and we're going to be fighting this out in court on behalf of our patients to get payment for the surgery. So yes, I expect once the insurance companies start coming around and making it easier for people to get this care with the laser surgery, that it's going to spread like wildfire, and all these screws and rods, they're going to go away. So all the surgeons now that are starting to learn how to put them in as new technology, they're going to be, you know, steamrolled by this real new technology, which is endoscopic. Great question. It is definitely the future of spine surgery because it's cheaper, it's safer, it's better outcomes than any kind of fusion or laminectomy or anything like that. And in the end, the patient is the customer, consumer, and the patients, once they know about it, they're going to demand it. Next question.
That's it.
I thought we had two.
You kind of already covered it. Will this surgery ever be covered by health insurance companies?
So will this surgery ever be covered by health insurance companies? Actually, it already is. It's not covered by all health insurance companies, but what surgery is covered by all health insurance companies? I don't know any surgery that's covered by all health insurance companies. Heck, people get denials for fusions all the time. And fusion is supposed to be, you know, accepted for the last 50 years. So insurance companies don't deny surgeries because the surgeries are bad surgeries. They deny surgery because they can get away with denying surgery because you're not challenging them. And in the end, when they deny your surgery and you don't challenge them as the patient who needs it, guess what? They just saved $100,000. That's $100,000 that goes to their profit margin, their bottom line, because they didn't spend it this year on you. Think about that. Every year, the insurance companies bill you monthly for your premium, and you're paying $1,000 a month. That's $12,000 a year for you, every family member, every worker in your company. Start doing the math. You're getting into billions and billions of dollars that they collect in premiums. And if nobody sees the doctor, nobody gets any medical care, they get to keep 100% of those billions of dollars you've paid them. The only time insurance companies spend money is when it's for your medical care and what they call administrative costs and research, which is bullshit because they don't really do it. Point is, as long as they can stop paying for your medical care, they can keep that money as profit. So yes, there are insurance companies that do pay for Deuk laser disc repair, and there are people that pay. We're hoping someday that all insurance companies will cover it, but that day is a long way off because it's going to take a lot of litigation. All right, thanks for joining us. I hope you enjoyed the surgery. We have one more to go, and our last patient is a 3-level, L4-L5, and I know she's going to be challenging because I've seen her spine, and it has a lot of arthritis and scoliosis. All right, we'll see you soon for that surgery in about 30 minutes. Thank you, Dr. Deuk.